Okie doke. We are going to start Unit 3. A lot of stuff here in Unit 3 should hopefully be kind of a refresher for you. We're going to talk about cardiovascular assessment. Again, not a lot of new information to you. Some of the stuff that I think might be new to you will emphasize more. But, you know, there's a lot of stuff on your slides about how to take a blood pressure and stuff. We're not going over all that, guys, because hopefully by now everyone in here has been taking blood pressures and having experience taking blood pressures. Okay, so we're starting, this is chapter 31, page 658 in your text if you want to follow along. So this beginning slide here, I always like to throw this in this Unit 3. Again, this is going to come into more play when we get to Unit 4, when we actually really start talking about Unit 4 and 5 is the heart, okay? But just a quick reminder of preload, contractility, and afterload. And then to give you an example of how to apply that, here's a practice question. And don't holler out your answer. Don't blow off your answer. Let everyone think about it. So a patient is receiving a drug that decreases afterload. To evaluate the patient's response to this drug, what is the most important for the nurse to assess? So look at that previous slide that I just showed you. Who wants to take a try at this one?
Blood pressure?
Yes, the answer is blood pressure. And why is that the answer, Vanessa?
Afterload is peripheral resistance against which the ventricle must.
Right, because afterload is peripheral resistance against which the left ventricle must pump. All right, in essence, your blood pressure. Okie doke. Okay, so structures and functions of the cardiovascular system. Arteries carry oxygen away from the heart. You guys know that. Except for which artery? Right, very good, because what's the pulmonary artery got to do? Yeah, it's got to get the oxygen, exactly. Veins carry deoxygenated blood toward the heart, okay? Remember, the heart pumps out oxygenated blood, the body uses it up, and it comes back to the heart, okay, via veins. But which vein does not carry deoxygenated blood? Pulmonary veins, very good. So the arterial system differs from the venous system by the amount and type of tissue. Obviously, arteries, we don't carry oxygen. Arteries are tougher, okay? Veins are a little less tough. Arteries have thick walls. They're mainly composed of elastic tissue, which helps with cushioning, helps cushion impact of pressure. Because in the arteries, there's high pressure. That's why if someone cuts an artery, it psh, 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 okay? When you cut a vein, it just kind of triples out, okay? There's a lot more pressure in an artery. What's the biggest artery in the body? What is it, Haley? Aorta, right? This is why people that sever their aorta, they're going to die, all right? Because it's a big artery. It's got a lot of pressure in there, okay? Also, some arteries contain smooth muscles. So that would be the aorta example of a large artery. The pulmonary artery is large. The innermost lining of the arteries is the endothelium. This is what maintains homeostasis, promotes blood flow, and inhibits blood coagulation. So again, when we talk about why people get high blood pressure, why people have vessel problems, it could be an endothelial injury, for example. Capillaries, those are very thin. There's no elastic, there's no muscle tissue. These are what connect arteries and veins together. And then veins, you guys know what veins are. They're thin-walled. They return blood to which part of the heart? Yes, right side of the heart. Veins bring blood to the right side of the heart. They jump on over to the lungs, pick up oxygen, go back out the left side, and we do this again. Okay. Also, the larger veins can sometimes contain valves at intervals to maintain blood flow. What is the valve supposed to be doing besides maintaining blood flow? They're pushing blood where? To the heart. We always want blood flowing to the heart. That's why when you start an IV, you always point the IV where? To the heart, right? So if you're starting a scalpel vein on your peds patient, point it to the heart, okay? If you're starting a vein like up here, like in the upper bicep area, make sure that the tip is always pointing to the heart, okay? So whenever you're starting a peripheral IV, you always point it to the heart, okay? Just like if you're starting a jugular, peripheral jugular, you don't go this way. You point it down to the heart. So you start it standing at the head of the bed and you point your tip to the heart, okay? The largest veins are, where do we put central lines in? Where do they end up? Where's the tip at? No, hopefully not the right ventricle. Put the patient in VTAC. Where? Superior and inferior vena cava, exactly. Superior being on the top, inferior being the bottom side, right? So if you put central line in the upper chest, you're doing the superior. If you did a central line down the groin, you're going to the inferior vena cava. So the largest veins are the superior vena cava, which returns blood to the heart from the head, neck, and arms, upper body, okay? And the inferior vena cava, which is bringing blood back to the heart from the lower part of the body. You guys know that. That's hopefully a nice review. Here's a picture. Arteries, vein. See how the difference between the vein and the artery, how much tougher looking that artery looks. It's got a nice thick muscular wall there compared to the vein. All right, blood pressure. The arterial blood pressure is a measure of the pressure exerted by blood against the walls of the arterial system. Systolic blood pressure is the peak pressure exerted against the arteries when the heart contracts. So systolic is when the heart contracts. What's diastolic? Resting, relaxing. So really, a more important number to look at, if you're looking at systolic versus diastolic, which number is more important to look at? Diastolic, because diastolic is telling you how much time this heart has to relax and for filling, okay? So if the heart doesn't have much time for relax and filling, that's going to be worse than the systolic blood pressure, which is just the pressure that's being exerted when the heart contracts, okay? Obviously, we look at both numbers together. They're both important, but sometimes you'll see a blood pressure 130/90, right? Which number are you more worried about, that 90? They're both borderline numbers, but if I were to get excited about either one of those numbers, it would be the 90, the bottom number, because that's telling me that our heart's not having very much time to relax and refill, right? So the two main factors that influence blood pressure, cardiac output and systemic vascular resistance. So blood pressure equals cardiac output with the systemic vascular resistance. Measuring blood pressure, we're not going to go over a lot of this because this is stuff you guys know. Review it in your book if you need to brush up on your skills. But we can use invasive and non-invasive techniques to check a blood pressure. What does that mean? What would be an invasive blood pressure? What's invasive mean? What, Daniel? Right, so what would be an invasive blood pressure? Right, and how do we do that? What kind of line, what kind of catheter do we use? Somebody's whispering, say it out loud. Be proud, say it out loud. Yes, an arterial catheter, an art line, exactly. That would be an invasive blood pressure. Okay, but remember, with an art line, you're getting arterial pressures, okay? So the invasive technique would be a catheter inserted into an artery, and then we can connect that line to a transducer, and it connects to our bedside monitor, our big cardiac monitor, and it constantly, there's always a number up there of an arterial pressure for the patient. And then a non-invasive technique would be like these showing up here, actually taking a manual blood pressure. Non-invasive can also be using the rolling carts and machines for blood pressures. Now, I will tell you guys, this best practice as a nurse, because I've seen this happen way too many times. You should always, always, always do a manual blood pressure on all your patients at the beginning of the shift. Why? Right, you want a baseline, but why else are you doing it? What, Haley? Right, the monitors are not always reliable, so you always want to correlate, is your manual blood pressure matching your monitor? Now, when you're taking blood pressures twice a shift, really you can do blood pressures manually twice a shift, right? Everyone's got time for that. But let's say you're working in an ICU and you've got a patient on a nitro drip and you're doing blood pressures every 5 minutes. Well, you can't stop sometimes when you're taking care of critical patients every 5 minutes to take their blood pressure. That's why we have machines. They're really great for that. But even in those situations, you should always do a manual blood pressure and then do a machine blood pressure and just make sure that they're correlated. They're not going to be exact. You're not going to get 120/80 manually and then get 120/80 on your machine, but they should be pretty darn close. And patients that have really high blood pressures and really low blood pressures, machines don't pick them up. I've seen it happen. I've seen nurses that'll take a blood pressure on the machine and it'll say whatever, really nice blood pressure, and then you take it manually and you're getting like 90/40. Okay, there's a big difference there. So especially when your blood pressures are high or low, the machines don't always work for those patients, okay? And then also you can, and then here's a picture of like a non-invasive blood pressure. Also you can use Doppler to get a blood pressure. Anyone in here ever done this? How do you do it? How do you take a Doppler blood pressure? No one's taken the Doppler blood pressure. One person in here has? No one else has taken the Doppler blood pressure ever?
I feel like I have it from the first year.
Probably not, because I don't teach first year.
Yes, and when you were in my first year, I had you for
Maybe it was over the summer. Anyway, anybody else? No one's taken a Doppler blood pressure. Okay, Haley, how do you do it?
Well, you use the Doppler to find out where the arteries, like you're eating first,
Okay.
you know where it is, and then you pump up the blood pressure cuff, and you look in for systolic, and then you document it, you just put systolic over.
When you're pumping up the cuff, how do you know when to stop?
Well, if you do the two-step, you do the two-step and you pump it up for 40 minutes until you can't hear the pulse.
That's how you do it. So a Doppler blood pressure, first of all, you got to find the pulse, okay? And you're going to do it right here in the antecubital. When you use the Doppler, remember guys, just like this picture showing you, you're trying to pick up the pulse, the blood flow through the vessel, okay? So the harder you push down with your Doppler, what are you doing to that vessel? Right? So when you do a Doppler, any pulse, you just lay it on there. You don't have to push. When you can't find it, pushing harder is just going to make it harder, or pushing down is just going to make it harder for you to find it, okay? Because you have your vessel here, and when you push that transducer on top of it, all you're doing is squeezing that vessel and making it even harder for blood flow to get through there, making it even harder for you to find the pulse. So when you Doppler blood pressure, put your cuff on just like you normally do, put your transducer on the patient, and you find your pulse, okay? That's step one. Once you hear the pulse, pump up your cuff, okay? When you stop hearing it, that's when you stop pumping, okay? Then you let it out, and the first time you hear the beat again, that's your top number, that's your systolic number. You will never get a diastolic number because you should have a pulse all the time, okay? If it stops, then your patient's dead. They don't have a pulse, all right? So just like Haley said, your blood pressure will be 90 over, you can chart it 90 over D for 90 over Doppler. Some, like for example, Epic doesn't let you put a D in, you have to put a numeric value, so it would be like 90 over 0. And you want to make a note that you're using the Doppler to get your blood pressure. So when would you do this? Right, if you cannot hear a manual blood pressure, you should always get a Doppler to correlate it with your machine, okay? You guys can all practice doing a Doppler blood pressure on anybody. Just practice, just do it in the clinical one day, just for fun, okay? Okay, there's Doppler. All right, pulse pressure, mean arterial pressures. Pulse pressure is the difference between the systolic and the diastolic, okay? So for example, you guys probably learned this in neuro, when you have a head injury, when your patient's herniating, what happens to pulse pressure? Widens, right? So when you have a patient that has brain herniation, their pulse pressure widens, okay? Pulse pressure is normally about 1/3 of the systolic. So if the blood pressure is 120/80, what's our pulse pressure? 40, right? And 1/3 of 120 is 40, okay? An increased pulse pressure may occur during exercise or in individuals with atherosclerosis, which we're going to talk about this unit, of the large arteries. Decreased pulse pressure. Who has decreased pulse pressure?
Heart failure?
Yes, heart failure people.
Elderly?
Okay, more specifically than the elderly. No? Good guess though. Heart failure and dehydration, okay? MAP, your mean arterial pressure, refers to the average pressure within the arterial system that is felt by the organs in the body. So especially when like you work in critical care, they look at MAP a lot more than they look at just the trending blood pressures, okay? Because this is, obviously we're pumping out this blood because we want to perfuse all the organs, okay? So MAP is going to tell you the average pressure that the organs are feeling. It is not the average of the diastolic and systolic pressures because the length of the diastole exceeds that of systole when the patient has a normal heart rate. So MAP is calculated as, who knows how to calculate MAP? So MAP is the systolic blood pressure plus 2 of the diastolics. Put that all in parentheses. That's what you're going to do first, okay? And then you divide it by 3. So our blood pressure is 130/90. How would we do this? Systolic plus 180 equals what?
310.
And we divide that by, what's our math?
3.3.
What is it?
103.3.
Okay, so a MAP greater than 60 is needed to adequately perfuse and sustain the vital organs for most people. When that number falls below 60, these people, their vital organs are underperfused and they become ischemic. All right, gerontology. One of the greatest risk factors for cardiovascular disease is age. Cardiovascular disease, CVD, is the leading cause of death in adults older than 85. It's also the most common cause of hospitalization and the second leading cause of death in people younger than 85. The most common cardiovascular problem is coronary artery disease secondary to atherosclerosis. So with an increase in age, the amount of collagen in the heart increases. So what does that do to the heart? If the collagen increases, what happens to the heart? The heart loses that snap, okay? Think of it like a muscle being stretched out, okay? When your muscles are nice and tight, you're nice and strong, you got a nice snap to the muscle, okay? When the muscle gets stretched out, there's not that nice snap to it anymore, okay? So the collagen in the heart increases, elastin goes down, okay? Because now think of those fibers in the muscle being kind of like jello. So they're going to affect the heart's ability to stretch and to contract. Also, one of the major changes in the cardiovascular system with the elderly is their response to physical or emotional stress. So in times of increased stress, there's a decrease in cardiac output, and that's systemic vascular resistance because there's a reduced contractility and heart rate response. The resting heart rate, so supine heart rate, is also not markedly affected by the age either. So when the, let's see what's on the next slide. Yep. So when the patient changes positions, for example, when they go from lying to sitting, that sympathetic nervous system pathway can be impacted as well, which can result in a blunted heart rate response. There's the second one, a decreased response to stress. With the older people, cardiac valves become thicker, they become stiffer from lipid accumulation, fat accumulation, again, that degeneration of collagen, fibrosis. The number of pacemaker cells in the older client, so this we're talking about up in the atrium, the sinus atrial node decreases with age. There's a decreased number of conduction cells in the heart. About 50% of your older population are going to have an abnormal resting ECG. The autonomic nervous system control of the cardiovascular system changes with aging. The number and function of beta-adrenergic receptors in the heart decrease. This is why they're a lot more sensitive to those beta blockers, for example. So a young person can tolerate a higher dosage of beta blockers. The arterial and the venous blood vessels thicken and become less elastic with age. Valves in the large veins in the lower extremities have a reduced ability to return blood to the heart. So again, this is why sometimes people that are older, your gerontology population, they might not have heart failure, but they might have problems with edema, okay? Orthostatic hypotension is estimated to be present in more than 30% of patients over the age of 70. Again, that's just a statistic to show you that they're more prone to being orthostatic. And what is orthostatic? Right, when they change positions, their blood pressure drops, and what else happens? What other vital sign do we look at, though? What's the heart rate going to do? Increase, right? So when you do orthostatic vital signs, you got to do blood pressure and pulse. They work together to distinguish orthostatic, okay? And you should do it from lying to sitting, sitting to standing. How long should you wait between them changing positions? Right, at least a minute, okay? So you don't just have them lie down, sit them up, and boom, take their blood pressure, okay? Most of the time with your elderly, why are they orthostatic? What do we need to give them? What? Hey, they're dehydrated, right? So usually we just give them, usually the first treatment for orthostatic, look at those meds and give them some hydration. Also, an elderly consideration, the postprandial hypotension, which is a decrease in your blood pressure of at least 20 that occurs within 75 minutes after eating. And your book on page 663 gives all the more in depth of the elderly, gerontologic assessment differences. I always just say the old people. You guys know what I'm talking about when I say the old people, which is going to be me probably soon. Okay. So assessment, again, we're not going to go over in-depth assessment. There's assessments laid out for you in your book, but you always want to ask them about history of their present illness, any past medical history. When we're talking about this unit and blood pressure in specific, look at those meds. Those are going to give you a big, and with any cardiac patient, always be looking at those meds, okay? What if they come in and their heart rate's 55? What do you think about that number? Low. What if they're on metoprolol? Now, okay, you want to know what their normal is, but what if you get a pulse at 55 and then you look at their med list and they're on metoprolol? Now, are you super excited about that 55? Because That's what the med's doing. Okay, the med's bringing them down. And then you always want to assess the patient. How are they tolerating that 55? Okay, by this level, your critical thinking should be, as students that are getting ready to graduate, you got to look at numbers. We look at vital signs all the time, but then there's a lot more to just looking at it and saying, as a first year student, you would look at 55 and say, oh my gosh, their heart rate's 55, this is abnormal, I got to do something. Now you're like, well, like Haley said, what is their normal blood pressure, or excuse me, their normal heart rate? What medications are they taking? Let me go assess the patient. How are they tolerating this heart rate of 55? Are they dizzy? Are they lightheaded? Or are they laying there and they say they feel completely fine? Okay, so as always, we don't just look at numbers. We got to look at the whole picture with the patient. Okay, so assess the patient's current use and past use of medications. A classic one I see all the time working as a nurse is people that are on blood pressure meds. And whenever I ask them about their blood pressure meds, my next question is, are you taking them as prescribed? It's classic. Patients say, well, I'm supposed to be on lisinopril because I have high blood pressure, but I don't take it anymore because my blood pressure is better. I'm like, that's why your blood pressure is better, because you're taking your lisinopril. So they stop taking it, and now their blood pressure is high. And another classic was, especially blood pressure meds, why else do patients stop taking them? Besides finances, why else do patients stop taking them? What's the side effect?
Referrals?
For just blood pressure meds in general.
Leaking.
Okay.
Orthostatic hypotension.
Right, they might get dizzy, they might become orthostatic. But patients feel better when their blood pressure, because they're used to all the time their pressure being 140 over 90, 150 over 90, 150 over 100. They feel fine. This is why hypertension is a silent killer. Patients don't have any symptoms until it gets really high, then they get a headache and they get a brain bleed, now they're having a stroke. But patients, when their blood pressure that they've been used to for years being 140 over 90, now all of a sudden it's 110 over 70, they feel like crap when they got a normal blood pressure. So they stop taking it because they feel dizzy. Some of those blood pressure medicines might give them headaches, okay? Classic reasons for people to stop taking their blood pressure meds. Or, especially when you're dealing with a population, like for example, the elderly, that might be on a fixed income, if partners are both on blood pressure meds, and this one needs to be on metoprolol, but this one needs to be on lisinopril, we can't afford both of them, let's just take the lisinopril together. All right, so you get to have low blood pressure today, and then tomorrow I'll take it. I'm telling you guys, I see this all the time. All right. Did anybody watch the first Roseanne episode?
I was just going to say.
I used to love Roseanne. I grew up with Roseanne, and me and my husband still watch all the reruns of Roseanne, and Roseanne is there. So DVR, when you graduate nursing school, you can catch back up with Roseanne. But the first episode, Dan and Roseanne were like, I'll trade you 3 Paxil for 2 blood pressure meds or whatever, because that was the point, they couldn't afford all their medications. So again, when you're looking at medications, make sure you're checking those over-the-counter meds as well, herbal supplements, prescriptions, because aspirin, everyone thinks aspirin's so safe, and it generally is a safe med, but patients think it's safe because they get it over the counter, okay? But aspirin, we all know, comes in the blood. Some of those medications over the counter to treat colds, patients should not be taking those with hypertension. Why?
They can raise blood pressure.
Right, they can raise blood pressure and heart rate, because what do those meds contain? Right, some sort of like pseudoepinephrine, ephedrine, exactly. A lot of those meds they've taken off the counter because they used to be really make patients have a lot of problems. And some of those meds you got to get behind the counter, but I think that's more they don't want you like buying a bunch of what's one of them that you have to get behind the counter? Claritin, you have to get behind the counter? Yeah, Sudafed, because they don't want you buying a bunch and then like, you know, making your meth lab or whatever. But so they track all that stuff. But those meds are contraindicated for people with hypertension or cardiac problems because they can raise the heart rate as well. And I've even noticed that when I always have all kinds of allergy problems. When I take those meds, I sometimes can feel like it makes you like flush and your heart might race a little bit more. That's what's going on. So again, with our medications, we always want to know the dosage. When's the last time they took them? Do they understand why they're taking the drug, the side effects? All right. And there's more information on here about getting a subjective and objective assessment of your patient. You guys can read in your book about the subjective assessments on your cardiovascular patients. All right, so objective assessment, obviously we're going to get vital signs on all of our patients. We want to look at their general appearance, vital signs, measuring their blood pressure in both arms. It's normal from arm to arm to vary by about 5 to 15, okay? But you want to use the arm with the highest blood pressure for subsequent blood pressure measurements. Take orthostatic BPs and heart rates while the patient's lying, sitting, standing. The systolic should not drop more than 20 when they go from lying to standing. The heart rate should not increase more than 20 when they go from lying to standing, all right? When you're over that 20, then the patient might be considered orthostatic. When we're talking about cardiovascular, we also want to inspect the skin color, hair distribution. What does that mean? Why do we do that? Who cares about the hair distribution? Exactly, blood flow. So especially when we start talking about peripheral vascular disease, when you look at those lower extremities and maybe they don't have any hair anymore, maybe they don't have quality blood flow to that area. You want to inspect the extremities for edema, rubor, clubbing we've talked about, varicosities, lesions, ulcers. Inspecting the large necks in the vein. Palpation, you want to palpate the upper and lower extremities for temperature, moisture, pulses, edema. Cap refill is going to tell you what? What type of circulation? What is it, Haley? Arterial, right? Exactly. Arterial, I lost my spot in my notes, sorry guys. Cap refill is used to assess arterial flow in the extremities. And then auscultation, an artery that is narrowed or has a bulging wall can also create a turbulent blood flow. This abnormal flow is called a bruit, okay? So you can listen to a bruit with your stethoscope. You feel a thrill. So you feel a thrill. When you hear the term thrill, it's because you have to feel it. You hear a bruit. You auscultate a bruit. You can auscultate the major arteries. You can auscultate the carotid arteries. Any of you in here can auscultate carotid arteries. What should you not do when you're assessing carotid arteries? Both of them at the same time. Thank you, guys. If you ever walk in a room and you see someone going, stop them, okay? Because what are they doing? Right, they are stopping arterial blood flow to the brain, okay? So one carotid artery at a time, okay? You can also auscultate the abdominal aorta, the femoral arteries. This all can be part of cardiovascular assessment. When you lay really flat, when you go home tonight, you'll see a little pulsating here where your aorta is. That's normal. No one in here has a AAA, I'm assuming. Y'all look really good if you do. All right, so when you go home and you see a little pulse here on your aorta, that's normal, okay? This is an example of whenever you take fetal heart tones, for example, okay? You always should listen for the babies when you put the Doppler on the belly. You can do this at the bedside. You don't have to go down to ultrasound and get some big fancy expensive test. You can do fetal heart tones at the bedside. But you should, while you're listening for the baby, you should also be assessing the mom's pulse at the same time, because when you're putting that on there, you're going to pick up the mom's pulse, okay? And I've known patients that have had a bad outcome because maybe the nurse was picking up the trying to do fetal heart tones and was getting like 140 and said, oh yeah, baby's 140, baby's good, we're all good. That was mom's pulse. Mom was dying. Mom ended up dying, okay? Mom came in first, she had fallen, it was a traumatic injury. But anyways, make sure whenever you're doing fetal heart tones, you're assessing mom and doing the baby at the same time, because they should be different, okay? Mom and baby's heart rate are not the same. General, healthy, mom should be under 100, baby should be over 100, okay? But when you're doing those fetal heart tones, you're going to pick up mom's heart rates. So whenever you're doing fetal heart tones and you're like, oh, baby's heart rate 70, oh my gosh, the baby's dying, how is mom's pulse? So just check mom's pulse at the same time, okay? All right. And this picture's in your book, page 666. Ooh, that's an ugly number. Common sites for palpating all the arteries. You guys should know these, okay? What if you can't palpate them? What do? Get a Doppler. What if you can't get a Doppler? Ooh, what if you can't get a Doppler? You should probably notify your physician because you're probably checking pedal, dorsalis, popliteal. You're probably checking circulation to the extremities, for example. And if you can't feel them and you can't get them with a Doppler, then there might be a problem. And we'll talk about that when we start talking about the aorta, for example, okay? So when you're assessing your patient, you also want to assess the rhythm. Is it regular? Is it irregular? The force. It's important to palpate each carotid separately. We talked about that. We want to avoid vagal stimulation. We want to avoid decreasing blood flow to the brain. That's important, right? You got to have blood flow to the brain. And we always want to compare arteries from one side to the other. Here's some more information on here about inspecting, palpating. What's the PMI? Point of maximum impulse. Yes, that's the best point where you're supposed to auscultate and listen to the heart. Where is the PMI? The apex of the heart. More specifically, where's the PMI? Fifth intercostal space, mid-clavicular line. That is the best spot you are supposed to auscultate someone's heart. Now, how many of you in here have seen in practice, we just put the stethoscope right here? Everybody does it, right? But where are you listening at here? You're listening at the atrium. You're listening at the top of the heart. You're listening at the base. This is the apex down here. The heart sits between, think of it to be a little more simpler to wrap your head around. The heart sits between your armpit and your sternum, okay? And the heart, the apex of the heart, the ventricle kind of tilts out just a little bit to the chest wall, okay? This is why patients, for example, when they're in a car accident and this chest hits the steering wheel, that they're driving an old car that doesn't have an airbag, or the airbag doesn't come out. See that happen. They're at risk for cardiac contusion. You should be putting those patients on cardiac monitors because they could have dysrhythmias because that ventricle sits right there next to that chest wall, okay? There's your PMI. There's where you're supposed to be listening. Men in general, when you're assessing them, it's easy to hear their PMI. Why? They don't have large breast tissue right in the way. And most of the time with our females, we're not going to say, roll over on your side, let me hug or heave your boob up over your shoulder so I can listen to your PMI. That's why you see a lot of times people are just listening up here, okay? But best practice to listen is the PMI. It's right underneath the breast tissue, okay? All right. What? Oh, okay. Anybody want to share a story? Yeah. Everybody good? Okay. Yeah, we gotta have a little fun in here. I'll tell you what, guys. If you've never had me before, you're never gonna make it through the nursing world if you don't have a little bit of humor. And I'll tell you, nurses usually always have a little bit of off humor. Okay. I'll tell you, we deal with a lot of stuff. I've seen a lot of bad stuff in my life. And there's some things you don't just you gotta have humor in your job. You're never gonna make it through this career. Okay. Just don't do it in front of patients or their families. They don't like it. Okay. Okay. So some diagnostics when we're talking about the cardiovascular system, serum lipids, so triglycerides, cholesterol, phospholipids. We're going to talk about these more when we talk about atherosclerosis. Triglycerides are the main storage form of lipids. They make up about 95% of fatty tissue. Cholesterol, this is a structural component of cell membranes, plasma lipoproteins. It's a precursor of corticosteroids, sex hormones, bile salts. In addition from being absorbed from the food in the GI tract, cholesterol is synthesized where? What organ? Right, cholesterol, liver, put those together, okay? Phospholipids can be another test we do. lipoproteins. So let's talk about cholesterol screenings here. So main ones we're going to talk about LDLs, HDLs. So the LDLs are low density lipoproteins. These are mostly cholesterol with moderate amounts of phospholipids. And then HDLs are about half protein, half phospholipid for cholesterol. And then we can also talk about the VLDLs, the very low density lipos. These are primarily triglycerides with some phospholipids and cholesterol. So a typical lipid panel is going to be your total cholesterol, your triglycerides, your HDL, and your LDL. So what do we want that LDL level to be, high or low? We want LDLs low, and what do we want HDLs? How do you get your LDLs down? What, Ron?
Avoid the fatty stuff.
Right, avoid all that stuff that's good, okay? And then how do we get our HDLs up? Good fats. What else can you do to get your HDLs up? Exercise, right? So nobody likes to exercise. Well, maybe you do. Does anybody here love to exercise? Don't be shy. Like, I know that they say that, like, exercise releases endorphins make you feel good. When I do exercise, I do like it, but obviously not enough to make me go, like, every day all the time. But right, so remember, nobody likes to exercise, so we all should be doing it because we all need good HDL. That's how you get your HDL up, right? And we all love to eat bad food at least once in our life, okay? And that's how you have high LDLs and eating bad food. We shouldn't be eating bad food, right? So like this weekend was terrible for me, for example. Saturday was my birthday, so I ate bad, what? Oh, thank you. Ate bad all day. And then yesterday was Easter. What did you do yesterday? Eat, right? At least I did. Okay. So elevations in triglycerides and those LDLs, those are what are strongly associated with coronary artery disease. And then an increase in the HDL is what will decrease your risk of coronary artery disease. So again, high levels of HDL serve as a protective role by mobilizing cholesterol away from tissues. All right, that's why we want more HDL. So again, a measurement of just that total cholesterol just by itself is not enough to determine, yes, you have good or bad cholesterol. They really do. They want to look at those HDLs and those LDLs to determine your cardiovascular risk. And before a patient has any lipid profile done, their cholesterol checked, what do we got to teach these patients before they have it done? I need to fast. I had a friend one time, she had her cholesterol checked, and she knew it was going to be high, but when it came back, it was like really bad. And I said, well, did you fast? Well, no. And she went and had ribs the night before. It's like, hello. So, anyways. All right, that's it for the diagnostics. Let's move on to chapter 32, our hypertension chapter.
How long do you fast for?
It depends on where you work. A lot of places have different measurements. I always tell patients 12 hours, but some facilities will say 8 hours. Does anyone know anything different? Like the 8 to 12 range? Does anybody where they work have something different? Okay. Okay. Well, and you know what? That kind of makes sense because, like, you should be able to go and eat something and it not take your cholesterol from like 150 to 400. But we also like to say, well, it was high because I just had ribs. Right, so again, it's going to depend on the protocol. I don't know if I asked that question with you, Marcy. It depends on the protocol where you work. Everyone might have something different. But good question. All right, chapter 32, hypertension. So we know that there's a direct relationship between hypertension and cardiovascular disease, along with a very high increase in having an MI, myocardial infarction. There's also a relationship between high blood pressure, hypertension with heart failure, stroke, renal disease. So hypertension is an important medical and public health problem. It's a big deal for us to track patients' blood pressures. Again, this is some nice statistics up here. Healthy People 2020 lists the number of adults with hypertension whose blood pressure is under control as one of the 26 high priority leading health indicators for the coming decade. So it's a big public health concern. And the thing with blood pressure, like I said, no one feels that they have hypertension. That's why it's called a silent killer. But what hypertension does on the organs, especially the kidneys, and the risk for stroke is where these, and the risk for MI and cardiovascular disease is where these patients have poor outcome from hypertension. So again, we talked about this. Blood pressure is the force exerted by the blood against the walls of the blood vessel. It's primarily a function of what two things? Right, cardiac output in your SVR, okay? Cardiac output is the total blood flow through the systemic or pulmonary circulation per minute. That's also described as the stroke volume, which is the amount of blood pumped out of the left ventricle per beat. Should be about approximately 70 mLs, and you multiply that by the heart rate for 1 minute. That's your cardiac output. Obviously, you don't want the left ventricle to completely empty out. We always want a little bit of blood in the heart, right? That's why when you look at like ejection fractions, no one's ejection fraction should be 100%. There should be something left over in there. That's why like 60, 65, those are good numbers. Systemic vascular resistance is the force, we talk about this, opposing the movement of blood within the blood vessels. So, blood pressure must be adequate, must be good to maintain tissue perfusion during activity and rest. And then again, the mechanisms that regulate blood pressure can affect your cardiac output, systemic vascular resistance. Our blood pressure regulation can change from seconds to hours, from days to a longer period of time, days to weeks. So those short-term mechanisms, for example, our sympathetic nervous system, our vascular endothelium, these start kicking in to fix our blood pressure within seconds to minutes whenever we have a problem with our blood pressure. Okay, those long-term mechanisms, so like our renal system, our hormonal processes, these start to help regulate our blood pressure up over a longer period of time. And we'll talk about this. So for example, the sympathetic nervous system, this is going to react within seconds after the patient's heart rate, after the patient's blood pressure drops. So it's going to increase that blood pressure by activating our SNS, or sympathetic nervous system. So the increased SNS will increase our heart rate, cardiac contractility, causes vasoconstriction. That's going to promote renin to come out of the kidneys. But remember, this cannot work forever. This is like putting a Band-Aid on a boat that's got a hole in it, okay? It's only going to work for seconds to minutes. Baroreceptors, specialized nerve cells called baroreceptors, are located in the carotid arteries and on the arch of the aorta. Also, baroreceptors help maintain blood pressure. When did you guys learn about baroreceptors? Probably in neuro. How about spinal cord injuries? What happened to those people's blood pressure? They got all sweaty. They couldn't poop. They couldn't pee. Does that make sense? Remember learning that? Yeah. Back to baroreceptors. When you have a spinal cord injury, there's blockage to baroreceptors. So baroreceptors have an important role in the maintenance of blood pressure stability during normal activities. They're sensitive to stretching. When they're stimulated by an increase in blood pressure, they send inhibitory impulses to this sympathetic vasomotor system. So again, they're stimulated when the blood pressure increases. That's why your spinal cord patient, they're blocked, they're cut off from control of this. So that's why that blood pressure keeps climbing. Okay, those patients have a hard time. And then if the blood pressure drops, then our SNS comes into play. Vascular endothelium can influence blood pressure. I said that, how especially the arteries are have endothelial tissue there, so if there's damage to them. The renal system, ooh, the RAAS system. You guys got to memorize it, know everything about it. I'm kidding, you don't. All right, you guys are like, okay. No, but the kidneys contribute to blood pressure regulation because they control salt, they control extracellular fluid, they control sodium and extracellular fluid. So we know when we retain sodium, what follows salt? Right, so if you retain salt, then you retain water, which causes an increase in extracellular volume. What happens is this increases the venous return to the heart, increases stroke volume, so all of those increase cardiac output and blood pressure. So the renin, angiotensin, aldosterone system, which you guys don't have to memorize, I was only kidding, also plays an important role in blood pressure. So what meds would we give those patients for their blood pressure? We're talking about the renin, angiotensin, ACE inhibitors, right? Because what do ACE inhibitors do? What do they do, Danielle?
They control, they stop it, or they can stop the conversion of the angiotensin.
Because angiotensin is a potent vasoconstrictor, right? Very good. That's enough on that. And the endocrine system also can influence our blood pressure. Okay. Hypertension. What is hypertension? You guys know what hypertension is. There's numbers in your book. Hypertension is defined as a systolic over 140, diastolic over 90. Pre would be systolic 120 to 139, 80 to 89. I believe there's a table in your book. What page is on that? 684. Thank you. 684 tells you all those numbers right there. Isolated systolic hypertension is when the average systolic blood pressure is greater than 140, with an average diastolic less than 90. And then there's different stages of hypertension too, depending on how the numbers go. You guys don't have to memorize the numbers for all the stages of hypertension, okay? Prescribers are going to use this more for prescribing what they're going to give patients. So again, the systolic blood pressure does increase with aging. This is why a lot of our older population is on antihypertensive meds. And to classify blood pressure, we have to make sure we're getting 2 or more properly measured blood pressure readings on 2 or more office visits. So no one just comes in and says, you know, today we got their blood pressure is 150 over 100, let's start you on lisinopril, okay? They're going to, probably what they're going to do is you're going to have the patient go home and track their blood pressures at home. Because what happens when the person comes to the office? What, Amy? Stressed out, they're nervous, and that white coat syndrome. Whenever they see a medical person, they automatically become stressed, okay? So a lot of times we're going to send these people home and have them track their blood pressure in a calming environment. They go to Walmart, CVS, whatever, get their blood pressure checked. All right, we're going to skip this question. Okay. So primary hypertension is elevated blood pressure without an identified cause. This is the majority of our patients that you're treating with hypertension. This is about 90 to 95% of hypertensive patients. So they have hypertension because they have hypertension, okay? There's no exact cause. It could include increased SNS activity, overproduction of sodium retaining hormones, vasoconstrictive substances such as, what's a vasoconstrictive substance? Coffee. Okay, chocolate. We're talking about like smoking, cocaine. Okay. Coffee and chocolate, you can come into the classroom and have your coffee and chocolate. You can't come in here and snort coke and smoke. Okay, so increased sodium intake, greater than ideal body weight, diabetes, tobacco, excessive alcohol. These are all some examples of what can cause unknown primary idiopathic hypertension. Okay. Now, secondary hypertension, this is when the patient's blood pressure goes up because there's a reason. So we need to treat that reason for secondary hypertension. And again, there's a small percentage of people, like 5 to 10% of people that have secondary hypertension. So secondary hypertension should be suspected in those people who suddenly develop high blood pressure. We're talking about really, especially, they're usually going to get a really high blood pressure, a severe blood pressure. And in your book on page 684, lists some causes of secondary hypertension. So their blood pressure is high because of these reasons right here, okay? So again, treatment of secondary hypertension is what? Treat the cause, right? We need to get their pressure down. We're going to do that, but we also got to treat these problems, these causes here as well, okay? And secondary hypertension is a big factor related to hypertensive crisis. Here's the pathophys of hypertension. You guys can read that in your book. Again, some risk factors, age, everything goes bad when we get older, right? Alcohol, excessive alcohol intake is associated with hypertension. Patients should limit their alcohol intake to what? What about men? Men can have 2 drinks a day, women can have 1. I don't know why, that's not fair, right? Why do men get more? So what is considered a drink?
A bottle of wine?
Yeah, not some people, yes. But maybe at home, a drink is to get a bottle of wine. But what would be equal to 1 drink for wine? Right, 5 ounces of wine is 1 drink. 1 beer is 1 drink, and not those big silo cans. All right, we're talking like a 12-ounce can of beer is 1 drink, okay? And then 1.5 ounces of liquor is considered 1 drink. All right, so not your whole bottle of Jim Beam. That's not a drink. Some people think it is. And we laugh about it, guys, but truly some people think it is. All right, and I will tell you, if you don't already know this, and this is not researchable, this is not in your textbook, but if your patient's an alcoholic, whatever they tell you to drink, at least take it ×2 because they're lying to you. All right. So alcohol can raise your blood pressure. Tobacco, we all know that all about smoking. Diabetes can raise your blood pressure. And when patients have hypertension and diabetes together, they're at even greater risk for organ disease from the combination. High levels of cholesterol and triglycerides are a risk factor for atherosclerosis, and hyperlipidemia is more common in hypertensive patients. Excess salt, gender, hypertension is usually more prevalent in men and young adulthood, and then after the age of 64, it becomes more prevalent in women. So we're talking about gender, young men, higher risk of hypertension, older women, higher risk of hypertension, okay? Family history, obesity, ethnicity. Why do we include ethnicity? What ethnic group is higher risk for hypertension? What? Right, African American people are at higher risk for hypertension. Sedentary lifestyle, again, that goes into combination with controlling your weight, also can raise blood pressure. On the flip side, increasing your physical activity can help be a treatment for bringing your blood pressure down, especially those patients that are borderline hypertensive that, well, let's see if you can make some lifestyle changes before we start you on antihypertensive meds. So cut out your salt, quit snorting coke, and start exercising, and hopefully your blood pressure will come down. All right, so here we go. Question. While performing blood pressure screening at a health fair, the nurse counsels which person is having the greatest risk for developing hypertension. Who wants to try this one? Go for it, Mary.
D.
What do you guys think?
A.
Why is it A? Good try.
I thought because he would always eat out a lot. He traveled a lot and might eat.
Okay, thank you for saying that, because this is an opportunity for test-taking strategies. What'd she do there? We're not picking on you, Mary, but this is a great example. Adding stuff to the question that's not there. How many of you in here do that when you take tests? Everybody should have their hand up, because you all do it, okay? Me too. I still take tests, guys. I have certification. So, right, thank you for giving that example, Mary. We're not picking on you, but I'm glad you said that. She's adding things to the question that's not there, okay? So, what's the answer here? You guys said A. What's wrong? You guys are right. The answer is A. What's the problem with A? Right, age and family history. So a history of a close blood relative with hypertension is associated with an increased risk for developing hypertension. Atherosclerosis is the most common cause of having a cerebral vascular disease, and hypertension is the major risk factor for cerebral atherosclerosis and stroke. All right, so again, genetics can relate to the pathophys of hypertension. Water and sodium retention, excess sodium intake is linked to hypertension. We talked about that. In general, the effect of sodium on blood pressure is greater for our African American population and our middle-aged and older adult people, because those are the people that are going to be more affected by salt in their diet when it comes to raising their blood pressure. Stress, increased SNS activity, altered renin-angiotensin aldosterone mechanism can lead to elevated blood pressure, insulin resistance, hyperinsulinemia, endothelium dysfunction. All right, so again, I said this, hypertension is often called we'll get through this clinical manifestations and then we'll be done, guys, okay? So hypertension is often called the silent killer. And why do we say that? What'd you say, Vanessa? You feel fine. Did you say something, Sarah? Sarah Schroeder? Okay, anybody else? Why is this a silent killer? Right, a lot of people don't know their blood pressure. What did you say, Lacey? Right, they feel fine, they're asymptomatic. Very good, guys. So what happens is it's considered a silent killer because it's frequently asymptomatic until it becomes severe and target organ disease occurs, okay? A patient with severe hypertension may experience a variety of symptoms secondary to the effects on blood vessels and various organs and tissues. So some of those secondary symptoms the patients might have are listed up here on your board for you. Now, a lot of times people think that, oh, when my blood pressure gets high, I'll get a headache, I'll get a nosebleed. Typically not. That's really high blood pressure to get a headache, to get a nosebleed, okay? A lot of times people can be walking around 150 over 100 and they feel completely fine, all right? I've seen people with blood pressures of 200 over 100 and they feel fine, all right? Symptoms of hypertension were thought to include headache and nosebleeds, but unless that blood pressure is really high, those symptoms are no more frequent in people with hypertension than the general population. Now, patients that are in hypertensive crisis might have these symptoms because these are people that went from a normal blood pressure to boom, their blood pressure jumped up really high, okay? So they get headaches, dyspnea, anxiety, nosebleeds. So the problem with hypertension is going to be when it starts to, let's do this slide. I promise we'll be done after this slide. The problem, because it just keeps going with what I'm saying. The problem with hypertension being a silent killer is that patients don't know they have it, like you guys said. Patients don't, they feel fine, like you guys said, until they start having problems here, okay? So the most common complication of hypertension is that target organ diseases. So hypertensive heart disease, cerebral vascular disease, peripheral vessel disease, when we talk about peripheral vascular disease, kidney disease, eye problems, so like retinal damage, for example. And your book on page 686 lists the manifestations of target organ disease. 686. So hypertension is a major risk factor for coronary artery disease. Hypertension disrupts that coronary artery endothelium. Remember that endothelium plays a big role in hypertension. Causes stiff artery walls, narrows the lumen. That's it for today.